All right, we will go ahead and get started. Tonight, I'm going to be talking about chronic pain management, pharmaceuticals, and beyond. Just some disclosures of some of the companies that I do consulting work for, as well as the companies who help fund my research. So to get a better idea of management of chronic pain, we have to really understand the impact of chronic pain on our patients. And we know that despite significant advances in pain management for companion animals in the past 2 decades, pain is still undertreated. And this is often due to the difficulty in recognizing and measuring pain in dogs and cats. Pain is a multi-dimensional experience with sensory, evaluative, and affective or emotional components. And so it's really hard to directly measure it. We can measure some of the sensory and evaluative components because we can say, like, how intense is the pain? Is it associated with some sort of insult? But then there's the whole emotional component that we know is a really big component on the human side, but we really don't think about that much in our canine and feline patients. And so what is chronic pain exactly? It's pain that's present for an extended period of time. However, it's not necessarily directly correlated with time. So there's not an exact time that's associated with chronic pain. It's more that the pain goes from an appropriate or physiologically protective response to more of a maladaptive response. And based on the studies that we have, we know that incidence of chronic pain is high in companion animals. About 1 in 5 dogs greater than a year of age have osteoarthritis. And we know in cats, it's potentially even higher. But we think about osteoarthritis as a big cause of chronic pain, but there are a lot of other causes of chronic pain as well. So things like neurologic diseases like intervertebral disc disease, inflammatory diseases, neoplasia, and even dental disease can cause significant chronic pain. And so we have to really think about what are the sources of chronic pain in the patients, and then how do we address them? The impacts of chronic pain, like we talked about previously, are multidimensional. So they affect your physiological systems, sensory, functional, so your actual movement, cognitive and emotional, social and societal and behavioral. And you can see on this little diagram how they're all interrelated. So they all kind of affect one another. And so we often think about, some of these in our, in human patients more than we do in dogs and cats, but really they do, all of these things do affect our veterinary patients. If you think about, social and societal, we think, oh, people. But really, if you think about, the cat who hides under the bed and doesn't interact with the owner anymore, or the dog who doesn't want to be touched because they're painful, so they kind of stay in a corner, they don't interact with their family as much. And these types of components also affect that human-animal bond. So not only is chronic pain important, from a welfare standpoint, but also from that human-animal bond standpoint. So pain assessment, this is the tricky part in our animals. We have some objective measures, but we know those can be pretty unreliable. So things like heart rate, respiratory rate, pupil dilation, hormone levels, you can measure them objectively, but are they actually correlated with pain? And that's one of those things that sometimes yes, sometimes no. So it's not super reliable. We can use force plate and gait analysis and activity monitors. There's studies that validate that, but not very many people have access to those types of methods. Mechanical sensory thresholds are typically just used in research. And so a lot of times what we're relying on are these subjective measures. So owner assessments or veterinary assessments, or a combination of both. This came out of the AHA guidelines, the most recent one, just showing kind of the methods that we can use to assess pain in our veterinary patients. So you have your physical exam, your observation when they're in the clinic, those physiological variables that we know are kind of unreliable. We can palpate, we can get videos from the owners, And then we get into more of the kind of advanced researchy type things like the force plates and the pressure sensitive walkways and activity monitors. And this is just another nice diagram from the AHA guidelines showing that, kind of how you evaluate acute pain versus chronic pain. And so this lecture will be focusing primarily on that chronic pain using kind of these screening tools. So the CMI is clinical metrology instrument, and then combining that with your palpation and your examination. And we'll talk a little bit more about those clinical metrology instruments in just a little bit. So what are the challenges of measuring pain in our veterinary patients? Obviously, there's species differences. Cats present very differently than dogs. It's the reason why we had, fairly good pain scoring guidelines for dogs well before we had them for cats. Cats definitely present, and show their pain a lot differently than dogs. And so, there's now the feline grimace scale and some of these other scales that take into account the more feline behavior compared to the canine behavior. And then even within the species, there are breed variations. And then within those breed variations, there's individual variation. Just like within humans, some humans have a very high pain tolerance and others do not. The other challenge is that we're what we call assessing by proxy. So since they can't verbalize to us, we have to assess them by proxy. So either through the owner or through our own assessment. And then that takes in, brings in this kind of respondent bias. So, the owner is biased, we're biased, and that can affect our pain measurements. This was actually a pretty interesting study that came out recently, that pain sensitivity differs between dog breeds, but not in the way that we typically think. And so this, goes back to that bias. We definitely, as veterinarians, tend to be a little bit breedist, and we say, oh, well, there are certain breeds that are super sensitive, like the husky. We all think of those screaming huskies that, are very dramatic. And then we think of dogs that are super stoic, like the pit bulls. And what they found was it did not typically trend that like we as veterinarians would have thought. So actually, some of the breeds like the labs and the goldens actually were more sensitive than like the husky, which was pretty surprising. So I think we need to try to be a little bit more objective when we're measuring pain and not really getting caught up in that kind of breed bias that we often kind of assume based on, some of the breed biases that we have. This is came from a little bit older of a review journal, but just goes through some of these clinical metrology instruments. So clinical metrology instruments are essentially these owner or veterinary kind of surveys that we do that, give us kind of a pain score. And so these are the ones that are validated. So the Canine Brief Pain Inventory, Helsinki Chronic Pain Index, the Liverpool Osteoarthritis in Dogs or LOAD. For cats, there's the Feline Musculoskeletal Pain Index, and then the Canine Orthopedic Index. And you can see these are all for osteoarthritis. And so while the conversation is, this topic is more chronic pain, we know that osteoarthritis is the leading cause of chronic pain in our veterinary patients. So there's going to be a little bit of talk, about osteoarthritis evaluation specifically, but really, this is, broader in the chronic pain context. So these are different kind of owner and veterinary questionnaires that can give us objective pain scoring. And while a lot of people think of them as being more research tools, and we definitely use them when we're doing research studies, you can build them into your practice. And, I really think that, we started kind of pushing more for the, doing pain scoring as the kind of fifth vital sign. And those are based on very kind of more acute pain scores, that we can build in some of these more chronic pain scoring into our clinical practice. It does take a little bit more forethought and leveraging the technicians, We can send these questionnaires to the owners ahead of time, and then utilize the technicians to kind of follow up. But I think it's a good thing to implement, because in order to treat pain, we really have to be able to assess where's the starting point and then where are they at after treatment. Otherwise, we're just kind of throwing treatments at them and being like, oh, I hope this helps. Did it help? I don't know. So I think that having a little bit more objective scoring really helps with our pain management as well as owner compliance, because if they're filling out the survey and they're seeing improvement, the surveys are showing improvement, we're making adjustments to our pain management plan, there's a lot more of a relationship building between the client and the veterinarian, better compliance, better, pain management for the patient. And we're really helping to preserve that, quality of life and the human animal bond. So I really think that building in more objective scoring to our, pain management practice is super important, really is a kind of a foundational piece. So we're going to kind of switch to talking more about pain management treatment. Now that we've kind of established, the difficulties of assessing pain and how we do assess pain kind of in clinical practice. So we're going to start out with pharmaceuticals, because while there are a million modalities and supplements and all of these newer things on the market, really pharmaceuticals are still our mainstay. And our goal for pharmaceuticals is basically polypharmacy. All of our chronic pain management is going to be multimodal. For acute pain management, a lot of times we can get away with one or two, pharmaceuticals or modalities. But once we get into the chronic pain, we really need to be thinking about the different levels of, nociceptive input, transduction, transmission, modulation, and perception. So the whole pain pathway. And when we're talking about multimodal pharmaceutical treatment, we really want to be picking pharmaceuticals that hit different areas. So we don't want to concentrate all of our, pain management on one of the kind of levels of that pain pathway. We really want to try to hit multiple levels to get the best pain control and the best coverage. And so transduction, we talk about the NSAIDs being a big one for that. Obviously corticosteroids, which we don't use as often in chronic pain management, the PIPRANTs and anti-nerve growth factor antibodies. Then you have transmission. So that's your opioids, your NMDA receptor antagonists. So that's amantadine and ketamine, gabapentinoids. So gabapentin, pregabalin, and then your cannabinoids. And then you get to modulation and you have your opioids, your tricyclic antidepressants, NMDA receptor antagonists, paracetamol or acetaminophen, cannabinoids, and then perception, also opioids, NSAIDs, paracetamol, gabapentinoids, and the NMDA receptor antagonists. So you can see that a lot of the drugs that we use do kind of hit multiple levels. And so I think that that's important that we have overlap and we're covering kind of multiple bases. We're not going to talk a lot about NSAIDs just because, everybody should, at this point, should be pretty familiar with them. But when we're talking about chronic pain, especially since most of the time that involves treating osteoarthritis in our veterinary patients, NSAIDs are still going to be the mainstay. Now, that could potentially be switching depending on how the anti-nerve growth factor monoclonal antibodies go. But for now, NSAIDs are still going to be the mainstay for osteoarthritis treatment. They're analgesic, anti-inflammatory, and antipyretic. We know that they inhibit COX enzymes, and then, we have our COX, we typically use our COX-2 selective NSAIDs in our veterinary patients. The interesting thing that I think we forget about a lot is that we think about NSAIDs acting on inflammation, in the periphery, so the joint or, the skin or in that kind of peripheral system. But NSAIDs also act on that central nervous system. And we know that COX-2 actually plays a role in acute pain sensation, and it's involved in spinal nociception central sensitization. So because that COX-2 is expressed in the brain and spinal cord, we think that COX-2 is actually contributing to that, what we call that neuronal plasticity, which basically results in this central sensitization. And since central sensitization is such a large component of chronic pain, NSAIDs are still, regardless of whether they've got osteoarthritis or whatever they have going on, if we're trying to prevent or decrease that central sensitization, NSAIDs are still going to be a component of that treatment. No single product NSAID has been demonstrated superior. So, any of these, can potentially be used. So your Daramax, your Carprofen, your, all of these, none of them have been shown to be superior to the other. Graviprant or Galaprant is a non-COX inhibiting prostaglandin receptor antagonist. It blocks that EP4 receptor. We know, everybody said when it came out, oh, it's safer. It still can have GI adverse effects. So vomiting is fairly common, diarrhea, inappetence. And we really don't know long-term whether it's that much safer for liver and kidneys than the traditional NSAIDs. And at least the studies that, do head-to-head for Galaprant versus other NSAIDs, the other NSAIDs definitely beat out the Galaprant. So while I do use it occasionally, it is definitely not my go-to unless the dog does not tolerate the traditional NSAIDs, in which case I'll try Galaprant. But I don't find that it has as good a pain control as the traditional NSAIDs, and that's supported by the literature as well. So gabapentin, and you'll note that I am not talking at all about tramadol. We know that tramadol is not super effective for pain management. It does seem to help in some cases, but overall, not super helpful. So gabapentin, when tramadol kind of fell out of favor, everybody started using gabapentin, and it was like, you get gabapentin, everybody gets gabapentin. And we really don't have any studies that support use of gabapentin in pain and chronic pain specifically in our veterinary patients. So the mechanism of action is that it targets the A2 delta 1 of the voltage gated calcium channels. The indication is chronic neuropathic pain. One of the cautions is in significant renal insufficiency, since it is cleared through the kidneys in patients that have severe kidney disease. Sometimes they have prolonged effects from the gabapentin because of decreased clearing. Adverse effects, we all know: sedation, ataxia, some GI issues. The dose range, I typically start out in the 10 mg per kg range and then go up. You can go up to 20 or even higher. The question is, does it actually do a whole lot? And we really don't have the studies to support it at this point. There have been some studies evaluating it in acute pain and basically say, it has no, improved pain control over the placebo or the control groups. So, I still use it, but it's definitely not as strongly supported as I think a lot of people think it is. And so, I think that it's something that we should be a little bit cautious about overusing just because we don't have the research to support it. However, the flip side of that is pregabalin, which is structurally similar to gabapentin. The nice thing about it is it has a higher oral bioavailability and a longer half-life. So a lot of times people dose gabapentin twice a day, but really pharmacokinetically, it needs to be every 8 hours to have its, full benefit. But every 8-hour dosing is really hard for a lot of clients. And so you have poor compliance, and then we just say, okay, give it twice a day. But really, like gabapentin, if you're going to use it, you need to be using it every 8 hours. So pregabalin is nice because of the longer half-life. It can be dosed at every 12 hours. And we actually do have studies for pregabalin. So there have been 3 recent controlled studies using it specifically for analgesia. These were all more kind of acute post-op type pain management as opposed to chronic pain management, but it definitely had showed, good analgesia compared to the studies that we have for gabapentin. So I definitely am reaching more for pregabalin now and transitioning a lot of my gabapentin patients to pregabalin. Ketamine. So ketamine is kind of one of these like hot topics right now. And it's one of, it's been around for a long time, and we typically used it as kind of that within that anesthetic protocol as opposed for chronic pain. But it's an NMDA receptor antagonist, so it reduces that central sensitization. It activates that descending inhibitory nerve activity, and then we can also produce that short-term local anesthetic effect. And so you can use it for acute pain and chronic pain. The side effects, these psychomimetic effects, but that's typically at more of the anesthetic and kind of acute pain management doses, not what most people are using for chronic pain. And so how do we use it kind of in a chronic pain setting? Now, the best evidence is going to be for IV infusions. So typically we're doing a bolus of 0.25 mg per kg IV, and then running a CRI at 2 to 10 micrograms per kilogram per minute for 4 hours. And so in people, they call these like pain vacations. People come to the pain clinic, they get their IV placed, they run ketamine, and then they go home. And so we can do that in our veterinary practices as well. And so that is something that we do. However, that's not always practical for some clients. And so there are options for sub-Q administration. There are sub-Q infusions. So there's a sub-Q pump that can be used where we skip the bolus and then we run the pump at home at 2 to 6 micrograms per kilogram per minute for about 48 hours. And then there's kind of what's kind of become really popular are these intermittent sub-Q injections. However, we really don't have any evidence at this point. The anecdotal dose, which really just came out of nowhere, I think maybe the first time it popped up on VIN was 0.5 mg per kg once a month. But that really was based on 0 studies. It was just somebody who kind of came up with this protocol. Now, anecdotally, we know, lots of people are using this, and at least, based on owner feedback, veterinary feedback, I've done it for patients. They do seem to do really well with this. But we just have to let the owners know that we don't have any actual research to support it yet. So there are, I do know of a couple of studies that are currently being done with regards to sub-Q ketamine. So I would hope that within the next, year or two, we'll have more concrete evidence to either support it or say, maybe we need to use a different dose or different dosing guidelines. But hopefully we'll have some more evidence for that, here in the near future. Amantadine is also an NMDA receptor antagonist. The indications are for chronic pain. The problem with this is there's only one study, and that was done in combination with meloxicam. So it was done in combination with an NSAID. The group that had the amantadine in addition to the NSAID outperformed the group that just had the NSAID alone. So it seemed that the amantadine did have a good effect. However, we don't know whether it's effective when used alone. So typically I'm using it as more of a third line drug. So, NSAID is going to be the foundation. Then I do pregabalin, and then I add in amantadine as my third option. And so I'm typically using it in combination with an NSAID unless the patient, for whatever reason, can't tolerate an NSAID. Cautions are hepatic and renal disease, and then adverse effects, GI and agitation. Dosing 3 to 5 mg per kg every 12 to 24 hours. I'm typically doing every 12 hours as opposed to every 24. Tricyclic antidepressants, we don't think a lot about these in veterinary medicine. They are one of the mainstays of chronic pain management on the human side. And part of that is because of the effect of the tricyclic antidepressants on that pain pathway. So we know it has effects on pain itself. But also, if we think about that affective or emotional component of pain, we know in people, chronic pain is significantly associated with depression. And then that depression can actually exacerbate people's chronic pain. So it's kind of this vicious cycle. We don't have that kind of documentation in dogs, but assuming it's similar, the tricyclic antidepressants are potentially nice because then you're hitting your pain pathways and maybe having an effect on some of the emotional component of it. However, we have no studies on using the tricyclic antidepressants in dogs. We have some pharmacokinetic studies saying that for amitriptyline, the dose is 3 to 4 mg per kg every 12 hours, but we really don't have any studies on using it for chronic pain. But it's something to kind of keep on the back burner if a lot of the other options are failing. So the nerve growth factor monoclonal antibodies, I think most people are probably familiar with these at this point, with the fact that Solensia has now been on the US market for about a year, and Librela just got released in the last month or so. So nerve growth factor is a soluble signaling protein that's released from the peripheral tissues kind of in response to a noxious stimulus. And it really has an important role in nociceptor sensitization in both acute and chronic states. And we know that nerve growth factor can increase peripheral sensitization, which then, has an effect on that central sensitization. And so it promotes pain and hyperalgesia. It, is also produced by a number of the inflammatory and immune cells. And so it's kind of this vicious cycle for chronic pain and inflammation, particularly when we're talking about joints. And so there's been kind of a big push to develop an anti-nerve growth factor monoclonal antibody that targets that nerve growth factor specifically. And so, on the feline side, Solensia is the, brand name. And then on the canine side, Librela or Vetmab, both are Zoetis products. The, nice thing about them is they're a once monthly sub-Q injection. In dogs, it's approved for greater than 12 months of age. Dose is 0.5 to 1 mg per kg. And then we know that it's been on the market in Europe for at least 2 years now. So based on the data that we have from Europe, we know that it's highly efficacious, and that even with over 6 million doses administered in Europe, there are pretty minimal adverse events reported. In cats, one of the more common adverse events reported is like a dermatitis. Sometimes it's pruritic, sometimes it's not. But the dermatitis is one of the more common side effects in cats. We don't see that in dogs with Librela. Dogs with Librela, PUPD, transient PUPD is one of the more common side effects. There, has been some concern with concurrent use with an NSAID. So, on the human side, this was a really kind of hot area of research, and there were multiple companies that were trying to develop a human monoclonal antibody for nerve growth factor. All of the clinical trials got shut down. And it was because they had rare but pretty severe adverse event where instead of helping the osteoarthritis, these patients had rapid progressive osteoarthritis, or RPOA. The question is, does that happen in our veterinary patients? And at this point, it has not been documented. The pharmacovigilance team at Zoetis says that they have not had any reports of the RPOA in dogs or cats. I've had some colleagues that have had some cases that they've been concerned about. So it's still a possibility and something to be aware of. On the human clinical trials, they found that the patients that were more likely to develop the RPOA were the ones that were on concurrent NSAIDs. Zoetis did do a safety study using NSAIDs concurrently, but it was a really short term, so only 2 weeks, and they used young, healthy dogs that didn't already have osteoarthritis. And what they were evaluating for safety was more like biochemical profiles. So could you use NSAIDs with Librela and have no biochemical changes? And so it was safe in that aspect. But there has not been any evaluation of long-term concurrent use of Librela or Solensia with NSAIDs. And at least the last time I talked to Zoetis, they said that they can't currently recommend administering Librela and an NSAID concurrently. So their recommendation is to, if they're on NSAIDs already, start them on Librela. They say that their improvement will be good enough within 2 weeks that within that 2-week period, you can wean them off the NSAIDs. So just kind of something to keep in mind as we start using this product more. So kind of switching gears from the pharmaceuticals to modalities, there are a lot of different modalities. Manual therapy is a big one, more on that we think of more on the human side. But we use it in our veterinary patients a lot. And, we can even teach the owners how to do a lot of these at home. So soft tissue mobilization and massage has effects on the pain pathways, as well as increases tissue extensibility, increases range of motion. Obviously, if we're improving range of motion and mobility, that can also have an effect on, improving pain and quality of life. Passive range of motion, stretching, and then joint mobilizations are all kind of fall under this umbrella category of manual therapy. We have some kind of studies on using manual therapy in dogs that have shown that they have improvement in comfort and mobility, but, smaller sample size, not controlled. And then one that looked at massage on pain and quality of life. So, that, can also potentially help. And then passive stretching on range of motion and osteoarthritic joints and labs. These passive stretching had, improved range of motion in the joints. And so, I think these are things that we can definitely build into our patients' treatment plans and teach the owners to do at home. That's always nice because then we get a little bit more owner buy-in that can improve the human-animal bond as they're kind of interacting, and the owners are actually having a kind of a direct manual effect on their dog's quality of life. Acupuncture has a number of effects. So it has local effects, segmental effects, and central effects. So it affects kind of that whole pain pathway. So that's kind of nice if we're talking about multimodal treatment. This is just kind of a, very complicated diagram of all of the different areas that acupuncture can affect. So, from your dorsal horn all the way up to, your supraspinal centers in the brain, it has kind of this multitude of effects on the body and on the central and peripheral nervous system. And then, an also complicated diagram of all of these, neurotransmitters and all of these, things that acupuncture also affects. There are not a ton of studies in dogs, but there are a lot of studies in people. Chronic pain is, one of the most costly, illnesses, morbidities in human medicine. And so, there's a lot of research on chronic pain management in people. And there have been quite a few large meta-analysis and review studies on acupuncture that show, effectiveness of acupuncture in chronic pain management. There are kind of mixed results in veterinary studies, but compared to the multiple hundreds of thousands of human patients, the sample sizes in most of our veterinary patients are really small. So it's very possible that we're just not getting a statistically significant effect because of the sample sizes. And here are a couple of the veterinary studies looking at acupuncture for treatment of osteoarthritis pain, or, in pain with dogs from hip dysplasia. Photobiomodulation therapy or laser therapy is the use of red or near infrared light to stimulate healing and provide analgesia and reduce inflammation. The mechanism of action is photons are absorbed by the chromophores and the respiratory chain enzymes and results in this whole cascade of reactions that affects changes in cyclic AMP, nitric oxide, and calcium. So, has kind of a multitude of effects, and also has effects on things like mesenchymal cell proliferation, synthesis of collagen, collagen organization, and then all of these kind of pro-inflammatory cytokines. The biggest issue with photobiomodulation therapy is that there are really no standardized treatment protocols. The study protocols vary widely with regards to dose, so your joules per centimeter squared, your frequency of administration, the actual wavelengths. And so it's really hard to make any definitive conclusions based on the studies that we currently have or compare study to study because of the differences. A couple of the more recent studies that show positive effects on osteoarthritis. There was a study just a couple last year out in AJVR on using it in dogs with hip OA. And they had improved pain scores, so these clinical metrology instruments and joint range of motion. And the surprising thing is that the effects lasted quite a long time after the last treatment, surprisingly. So that was, pretty positive. And then the Looney study looked at dogs with elbow OA, and they had improved pain and lameness scores and didn't need as many NSAIDs. The one thing to note in both of these studies is that the dose is higher than a lot of times what we talk about using for chronic pain. So at least when I originally started using laser therapy, they typically said, somewhere in like the 1 to 2 joules per centimeter squared for acute pain, and then maybe like 8 to 10 joules per centimeter squared for chronic pain. It seems like the dose needed for actual effective chronic pain control might be higher than what we originally expected. So this is something to keep in mind if you're not manually setting your laser. Depending on which laser unit you have, many of them have built-in protocols. So it's important to know what the actual settings of those protocols are, what the joules per centimeter squared that they're calculating it off of. So, if you're not seeing a good improvement with your current laser protocols, it may be that they're just too low and you might have to manually adjust them. Extracorporeal shockwave therapy is focused high velocity sound waves. They produce kind of a high amplitude pressure with this kind of short buildup time, and then this exponential decay followed by this negative pressure. The important thing to note is shock waves differ from ultrasound waves. So they're both sound waves, but shock waves have a lower frequency and kind of a minimal tissue absorption, and therefore kind of a lack of thermal effect. So when we're using therapeutic ultrasound, our goal is to heat the tissue and improve the extensibility of the tissue. For shockwave, we don't want that thermal effect. We want more of that mechanical effect. And the goal is, well, it depends. We have effects on the soft tissue, we have effects on bone, and we know we have effects on analgesia. The important thing to note, if you're looking at shockwave units, or if you have shockwave and you're trying to develop protocols, is there are 3 types of focused shockwave units. So you have electrohydraulic, piezoelectric, and electromagnetic. Radial shockwave is called shockwave, but it's not focused. And so it's not a true shockwave. It's more of kind of a pneumatic mechanical concussion. And so if you're looking at studies or you're looking at protocols from one unit to another unit, they all have different energies and properties. And so the protocols are not equivalent or comparable between the electrohydraulic, the piezoelectric, and the electromagnetic. So that's important to know when you're reading studies and it says, oh, use, this kind of dosing. You really have to know which unit they're talking about and whether that's the same unit that you have. So it exerts direct and indirect mechanical forces on the bone, soft tissue, and muscle, protects chondrocytes and disintegrates calcifications, recruits stem cells to treatment site. So we use it a lot for soft tissue injuries, tendinopathies. We can use it for bone healing, in the, non-healing fractures, in slow healing, post-op TPLOs. And so we use it for a lot of different things. But if we're talking more about chronic pain, we do know it has an effect on analgesia, but we really don't understand the mechanism of action for why it has that analgesic effect. There aren't any studies specifically on using it for pain in dogs, but there are studies on humans for using it for, specific areas of pain. We also have a study in horses that had back pain that it increased the mechanical nociceptive threshold or, decreased that pain sensitivity. So we know it does affect pain. We don't have any, good studies in dogs. We do know that it does seem to improve comfort and mobility in dogs with osteoarthritis. So there have been multiple clinical trials looking at shockwave in dogs with hip dysplasia, hip OA, stifle OA, and hip and elbow OA, where, pain and lameness scores are improved. So it's, definitely something that we can use. We just don't have a lot of good clinical trials on, what the mechanism of action is and what the appropriate dosing is. This came out of the Veterinary Clinics of North America, out of Leilani Alvarez's chapter for shockwave. These are kind of general treatment protocols, but once again, this is specifically for the PulseVet unit. So this is an electrohydraulic unit. These energy levels and pulses are going to vary if you have a different unit. But for the PulseVet, this is typically what we're using. Pulse electromagnetic field therapy, mechanism of action is it enhances binding of calcium to calmodulin, and then that activates that synthesis of nitric oxide and has this whole downstream effect. We actually have some pretty good prospective double-blind placebo-controlled studies for the pulse electromagnetic field therapy. So these studies were specifically done using targeted pulse electromagnetic field therapy, so the Assisi loop. And they showed that wound healing was improved. They didn't need as many pain medications administered in the pulse electromagnetic field therapy group. And then in this one study, the mechanical sensory thresholds were higher. The neurologic status for these patients was better. So, we definitely have some good evidence of using the pulse electromagnetic field therapy for at least, these studies were obviously done in post-op hemilaminectomies. So for the post-op neuro patients, we have studies. And I know that I'm pretty sure that there's studies being done for some other conditions as well, for other pain conditions currently. But we do at least have some really good, solid evidence for pain management, at least kind of in these contexts. This study was a slightly different type of pulsed signal therapy, but they used it in dogs with osteoarthritis and also had benefits. This is just kind of a chart from Assisi loop, using it for pain management, for, primarily kind of in that acute pain management setting, but we also use it for chronic pain as well. Transcutaneous electrical nerve stimulation activates these large diameter afferent fibers. activates these descending systems to reduce hyperalgesia, and has effects on the peripheral and central mechanisms. The nice thing about this unit, also, the assisted loop is nice because you can send it home with the owner. So it gives the owner something to do at home. Particularly, I see my patients more often than, I did in general practice. I'm seeing, patients often, once, sometimes even twice or 3 times a week, or at least like every other week or so. So this gives them something to do kind of in between when they see me for treatments. But the TENS is nice because, once again, the owners can use this at home. They're actually pretty inexpensive. I think they typically run like $35 on Amazon. What I typically do is since the pads have to stick to the skin, you basically have to shave the patient in the areas that you're going to stick the pads. And so I pre-shave the dog so that the owners have kind of an anatomic landmark, where they can stick the pad. And then I teach them how to set up the settings, and then they can administer at home. Usually about 15 to 30 minute treatment time, and 1 to 2 times a day. This is nice in kind of some of the post-op patients, but also some of the chronic pain patients. I like it a lot for patients with cervical pain. Those dogs can be pretty uncomfortable, but if you treat that cervical region and the owners are able to do that at home, a lot of times that has a really good effect. Same with low back pain. So a lot of times the spinal pain responds really well to this. Heat therapy, we know that heat has physiologic effects, so it increases circulation, produces analgesia, increases that soft tissue extensibility, relaxes muscle spasms. And then kind of on the opposite side, we also have cryotherapy. So both have effects on analgesia, but through different mechanisms of action. A lot of times people always ask me which is better, heat or cold. And most of the time it varies. And so obviously in the acute inflammatory setting, immediately post-op or kind of acute injuries, you want to avoid heat. You don't want to create any more inflammation. So in those cases, for sure, I'll use ice or cold therapy. In the chronic pain patients or the, osteoarthritic patients, some patients respond better to heat. Some patients seem to respond better to cold. And so most of the time, what I tell the owners is to experiment, see if their dog seems to prefer one or the other, see if their mobility seems to improve with one versus the other, and kind of play around with it, because some, definitely respond, better to one versus another. Other important considerations, obviously this is kind of beyond the scope of this particular talk, but the biggest thing that we can do for our veterinary patients for, at least for osteoarthritis, but even a lot of the other pain conditions, if you're talking about intervertebral disc disease, or even some of the neoplasias, weight management is going to be key. It is one of the best ways to reduce osteoarthritis pain. And so, this dog, the first thing I'm going to do is work on weight loss. You can throw all the pharmaceuticals at this dog. You can put this dog on NSAIDs and gabapentin and amantadine and Librela, and it's not it may improve the dog's comfort somewhat, but it's really not ultimately going to improve this dog's mobility or the quality of life or the dog's longevity. Weight management is going to be key. And that, goes along with exercise. So exercise is an important consideration for pain management. We know that exercise can, improve people's pain scores. We know that it improves dogs with HipOA, their, mobility and their comfort. Obviously, things like environmental modifications. So, addressing slippery floors, making sure dishes are at an appropriate height and an appropriate location, all of the, nail care, bedding, all of these things that, play a role in helping our patients be more comfortable. And then we have, a whole slew of nutraceuticals And then we can also consider, for our chronic pain from osteoarthritis, intra-articular injections. And there are a bunch of different types of intra-articular injections, from your orthobiologics like PRP and stem cells, to steroids, to hyaluronic acid, to newer hydrogels like Arthramid. And so there are a number of things that you can put into joints. And that would be a whole another lecture, but I'm happy to answer questions about those. And here is that same dog after a weight management plan. So weight management first, and then all of the other pharmaceuticals and modalities. But basic take homes is that treatment of pain relies on appropriate assessment. So if you can't say that a patient is in pain, you don't know whether you can treat it or not, right? So we have to be able to say, is this patient painful or no? And then if they're painful, having that assessment to be able to evaluate your response to treatment. And pain is individualized, so treatment should also be individualized. No patient is going to have the exact same pain management protocol as another patient. So take advantage of this polypharmacy, the multimodal treatments, so combining modalities that have different mechanisms of action, combining pharmaceuticals that have different mechanisms of action. And then once again, these assessments are key. So regular reassessments. And I think this is something that, we probably, and I will be, completely honest that I was not very good about when I was in general practice, is trying to get these kind of chronic pain patients in for more regular reassessments. Obviously, now that I do rehab and I'm seeing patients on a regular basis, it's easy. But I think that we need to probably leverage our staff a little bit better and build in some of these assessments and kind of regular reassessments into kind of our chronic pain management protocols in private and general practice to really best help our patients.